clinical case discussion in ophthalmology. Today, we are going to discuss a very interesting case of neuro-ophthalmology. The patient was a young male patient who presented with decreased vision in both his eyes with an onset of headache since the last 20 days. He's 22 years old. His visual acuity was hand movement on the right side and counting fingers on the left side. On confrontation visual field, it was very difficult to assess the degree of visual field loss. The cup to disc ratio was 0.5 in the right and 0.3 in the left eye. The intraocular pressure was 19 millimeters of mercury in the right and 18 millimeters of mercury in the left. We ordered a optical coherence tomography in which normal foveal contour and thickness with normal foveal thickness of 255 in the right and 248 microns in the left eye. There was no abnormality detected in the foveal region that could be a cause for his visual loss. But the interesting thing is when you go on to look at his OCT of the optic nerve, there's reduction in thickness of the retinal nerve fiber layer more on the right than the left. It was 73 microns in the right and 83 microns in the left. An important thing that you see is the thickness is reduced more inferiorly than superiorly. The visual field were ordered automated static visual field perimetry showed significant visual loss. It seemed like as if he could not see anything out of that eye, although he seemed to have good fixation in both eyes. But probably might have a learning curve and he might have slight central vision in his visual field, but on his first go he did not show anything. Looking at it, there was no optic disc swelling, so the diagnosis initially was bilateral retrobulbar neuritis, which might be seen. So an MRI scan to check for demyelination and compression of the optic chiasm was ordered. And symptomatically, the patient was given vitamin B12 as methylcobalt to be taken as once a day. And then the patient was followed up after the MRI scan report was retrieved. Important thing in these cases with bilateral decrease in vision is you need to look at what is actually causing the reduction in vision, which is sudden in onset rather than gradual onset visual loss. It is something which might be compressing on the optic chiasm that could lead to such a lesion. That is why an MRI of the scan was ordered, and that revealed there's evidence of intracellular soft tissue intensity mass lesion with both solid and cystic component measuring 38 into 19 millimeter in size, and no evidence of compression of third ventricle or hydrocephalus. There's compression and upward displacement of the optic chiasm, and no encasement of bilateral internal carotid artery or cavernous thrombosis seen. No recent or remote ischemic consultant identified. There is no midline shift. Brainstem and cerebellum appears normal, and cervicomedullary junction was normal. Here you can see an axial MRI scan on T2 weighted. You can see this is the lesion. Craniopharyngiomas can be cystic or they can be solid. This is the whitish lesion which you're seeing on a T2 weighted scan over here. And this is obviously, if you go and look at the pathology, it is remnant of the Rathke's pouch which comes from the pharynx. Here you can see the craniopharyngioma pressing the optic nerve. And this is the cleft which is left by the Rathke's pouch where actually the cyst grows, and this forms as a solid or a cystic lesion and which compresses on the optic pituitary gland and also then goes on to compress on the optic chiasm, which lies anteriorly over here. So the impression was an intracellular soft tissue density mass with both solid and cystic component suggestive of a craniopharyngioma as described, and a contrast study and biopsy correlation was advised. So it was very important that we were thinking of something which could be just retrobulbar neuritis, but it came out to be craniopharyngioma because patient presented with headache, and if we thought there would be a raise in intracranial pathology causing a space occupying lesion, there would be some papilledema, and there would be some optic disc atrophy. But The patient had just slight reduction in retinal fiber thickness. So, what is a craniopharygioma? It's a slow-growing tumor arising from the vestigial remnants of the Rathke's pouch, which I showed before, along the pituitary stalk, and it affects children between the ages of 15 to 14 years of age. And our patient was slightly older in age. Starts as a bitemporal inferior quadrinomia because it presses from below and lead to bitemporal hemianopia by compressing the optic chiasm. This is opposite to a pituitary adenoma, which would start as a bilateral superior visual field loss. The treatment which is available for this is surgical removal, which can be done with an external surgical craniotomy or a minimally invasive transsphenoidal approach. Radiotherapy has been used postoperatively, and chemotherapy has been injected into the tumor for this. Hormone therapy, if pituitary function are compromised, which they are, this patient was actually referred to a neurosurgeon, diagnosed with a pituitary apoplexy, and he advised minimally invasive surgery to remove this tumor. So, come to the end of this case. Thank you very much for watching, and please subscribe to our channel for more videos. Thank